Welcome everybody to the Part B webinar for Silica for artificial stone engineering, stone and countertops. This is more focused on control. And so the last webinar was the 2nd of February. Dr. David Goldsmith, who's an epidemiologist, actually led that. And so David's actually co-hosting this with me as well today. So we kind of work in tandem, which is great. So I just want to welcome you. I've got a slide deck, which I can open shortly, but I'll hand you over to David before I go there. Thank you.
Yeah, Kevin, thank you very much. And I want to take this opportunity to salute you for working with us on this issue. This is one that has been brought to our attention and has really risen in terms of a level of concern because countertop workers, starting some 10 years ago, were 10 plus years ago, were of concern because they had high rates of accelerated and acute silicosis. And the studies, the earliest studies on this came from Israel, from Spain, and subsequently from the US and Australia. And that has also now been followed by findings in other countries. And I just wanted to briefly mention Italy as being one of those places. And this has led us at WHWB, US WHWB International, to try and bring a seriousness and expertise to share with everybody about what's going on. And I'm very pleased to have you all on. I'm going to turn it over. I'm going to turn it back to Kevin.
Thank you, David, and hello, everybody. And it's great to have you all back again to the Part B webinar. So artificial engineered stone countertops. Really, this one's more around controlling exposure to silica. And we're also going to be talking about advocacy as well. And you might want to consider joining WHWB. So it doesn't cost anything to join the international WHWB. We've actually started up a healthcare working group as well, and we've had about 9 meetings from the healthcare working group. So for those of you on the call that are, doctors or occupational physicians, please consider joining. This is the agenda, and we've got a kind of a fairly full, like a complete bill here, full bill, and I'll go through it more at the end. But just to, we have got a good cast of speakers from around the world, and we're very grateful for Dr. Graham Edwards to help us open up the session. Dr. Melanie Gormaning from BC, Canada's going to be talking more about the Silica control tool. Dr. Susan Hamling from the Health and Safety Executive, Dr. Alison Fortner from NIOSH, Jason Green, he's our WHWB Australia connection. Thank you, Jason. And Kate Cole, she's actually taking her kids to school this morning. So she said she has a half-hour window to talk about the advocacy that she's doing as well. And then we're going to have just a panel discussion. So I kind of got the spreadsheet that Marianne sent, and I did a quick kind of did the sums, and these are all the different countries that registered. So most of the people are from the US, then South Africa, then Canada, then Australia, UK, India. But you'll see there's a lot of other countries with 1, 2, or 3 people. But we've got 48 countries registered. Typically, we end up with about half of those attend from the registrants list. I just want to do an Indigenous land acknowledgement. I would like to begin by acknowledging that I am speaking from Ottawa, Canada, and in respect to all First Nations, Inuit and Métis peoples and their valuable past and present contributions to this land. As I am in Ottawa, I'm also located on the unceded territory of the Anishinaabe Algonquin Nation. This is WHWB's strategic framework. You'll find it on our website. So, we're really, this is also about underserved populations. We're volunteers. We do this in our spare time. We're passionate about people's health, and we've actually expanded our vision some time ago, not just workers but families and communities as well. We also have, if you have a look on this slide here up to the top left there, we have memorandums of understanding and collaboration. So we have a memorandum of collaboration with NIOSH. It's great to have Alison speak from NIOSH, and also a memorandum of understanding with the Occupational Hygiene Training Association. So we work closely with them when it comes to training. And they do actually have training material freely available, no charge, that can be downloaded, that can be rolled out globally on Silica. And you can have a look there and see that information. There are approved training providers. WHWB is an approved training provider, as are many other around the world. Also, the UK branch has awareness course, the respirable crystalline silica, more of a kind of just to raise awareness. And this might be more for the, the general OH&S person, but that's just a snapshot. You can get through their awareness training there. So thanks to the UK branch. And I just want to recognize my colleague, Dr. David Goldsmith, who's he's just so passionate in this area. I met David years ago at a conference, and he just seems to be unstoppable. He keeps being the catalyst for these webinars. So, and this is just a book that he wrote a chapter in. So David's kind of specialty is looking at this particular chapter is looking at the carcinogenic evaluation of crystalline silica. I just want to quickly share some of my research from Queensland, Australia. When I worked there as an inspector, I was lucky enough to do a PhD while I was an inspector, and I focused on the Helidon sandstone area. And typically they've got big blocks of rock containing high concentrations of sandstone. They're highly exposed, but there's good cross section of workers to look at. And I was able to use an easy one spirometer and a cyclone to measure respirable crystalline silica on the same workers. So the excavator operator that I just showed you, this is his chart from his lung function test. Not very good. And then what I did was looked at similar exposure groups, and I grouped them into tertiles, and I was able to get a dose response curve to show that even at 0.1 milligram per cubic meter respirable crystalline silica, there was still a loss of lung function. FEV 1% predicted. So Dr. Claire Wood was the catalyst behind a letter, and I know she worked closely with Dr. Graham Edwards, and this letter was drafted and it was sent to ministers in Australia, and with a number of recommendations. And there was many recommendations, including lowering the exposure limit of silica from 0.1 to 0.05. But it's just a really good collaboration. And really, the recommendations were coming from the Royal Australasian College of Physicians and the Thoracic Society of Australia and New Zealand. And I've just got a screenshot there. Call for regulators to address public health crisis in the artificial stone benchtop industry. And also the first webinar, and it was actually Dr. David Goldsmith that got others involved, including Dr. Robert Harrison, who's done a lot of work in California. And Dr. Harrison, Robert Harrison, actually talked about the first index case in California, and that was kind of the lead on to tracking the silicotics from people working with engineered artificial stone. And this is just a snapshot from what he presented, just showing the imports into the United States of these quartz-containing materials. I just kind of grabbed a couple of papers just to give you a snapshot. A lot of people have been sharing a lot of papers with me, so I apologize if I haven't got your paper up there, because I know some really good stuff come from Australia as well. There's just two papers, one from Texas, and I think Bob Harrison talked about this, but not only talking about silicosis, but also work-related asthma. phthalic anhydride. I'm just wondering if you're not speaking, could you mute your computer, please? And the second one, compositional structural analysis of engineered stones by Leon Jimenez. I think it's a paper from Spain. I just noticed that there's higher levels of aluminum as well. So if we're kind of cutting this, grinding it and working it and forming really small particles, those tiny particles of aluminum, what are they doing to our neuro system? This was the second webinar, and it was a much broader webinar, and there's a hyperlink to that. So we kind of looked at a lot of different issues, including silica tuberculosis and silica dust polysis. It's kind of a broader webinar, but once again, Robert Harrison talked about the artificial stone, and Dr. Harrison talked about it as silicosis in a box. So it kind of really got David and I thinking about we should really hone in on artificial engineered stone in countertops. So the part A was how big is the problem? And this is just from Ryan Hoy's, one of Ryan Hoy's slides. And you can see in Australia, they've done a lot of work there. They've increased media attention, and now they do screening. And unfortunately, when you look, you find there's been many silicotics discovered there. So this is just a paper that was developed across Canada with different researchers, and it was a scoping review to identify strategies that work to prevent 4 important occupational diseases. It was a scoping review, as I said, and we demonstrated legislation regulations can be effective means of primary prevention, but their impact depends on both the nature of the regulations and the degree of enforcement. We also talked about the importance of screening as effective prevention tools for evaluating the impact of legislative policy change. And the effective education, so I talked about the OHTA training, which really needs to be rolled out in this area. It's context dependence and influenced by a manner of delivery. It's really multifaceted interventions are more effective. This is just something that I found from Australia. A few people talk about eye care, and this is New South Wales. It's a service that's offered, and there's a lung screening bus there that will go out to workplaces. So that's the introduction. Welcome everybody, and I would now like to hand you over to Dr. Graham Edwards. Thank you, Dr. Edwards.
First of all, a disclaimer, conflicts of interest. I was a member of the National Dust Diseases Task Force that ran from 2019 to 2021, and I was commissioned by the task force to chair the working party to develop the national guidance for doctors assessing workers exposed to respirable crystalline silica. While it was focused initially on the engineered stone kitchen bench tops, the countertops known elsewhere, the important disclaimer I have to make is that I'm not speaking on behalf of the task force, nor in one of my other capacities as a spokesperson for the College of Physicians or the Faculty of Occupational Environmental Medicine. I'm a consultant physician in occupational environmental medicine here in Brisbane, and it's all about health risk management in my practice. So in part B, we're talking about controlling exposure. In the last workshop, I spoke about the lessons learnt from the task force, the development of the national guidance for doctors, highlighting that labels matter and not all cases are progressive. And in Australia, we don't have a CDC. What we now have a much more functional Office of Health Protection, and we're establishing a National Occupational Respiratory Disease Registry as a result of this whole debacle associated with what I would term the warm-up pandemic for COVID. It certainly is worldwide. It is it behaves essentially as a pandemic, but with a much longer latency between exposure and disease. And the other attribute at the national level that's happening is that we've got the National Silicosis Prevention Strategy and Action Plan that is currently being rolled out. And we just recently, we've had another budget allocation to support that activity. The other headline issues that I covered last time, and I would encourage people to go into the WHWB site to actually gain access to all the recordings from the last sessions, is we developed and looked at the case finding activity and the case management activity. One of the key attributes that we're now seeing is the rollout of the recommendations of the task force. And so regulatory reform was a really important part of it. What we found is that the regulators were asleep at the wheel. While we had regulation, they weren't being policed. But one of the reasons it wasn't being policed because they didn't have an adequate code of practice to police. So if the inspectorate doesn't know what to inspect, then it's pretty difficult for them to regulate. So we've had to develop the regulatory reform, which is still a work in progress. We've got now codes of practice in practice. One of the key elements to control is in Australia, we have the advantage of not having any manufacturing of the product on our shores. And so what we can do through bills of loading is actually identify the product coming across the borders. And one of the early initiatives that we were able to implement was linking the border control data with the inspectorate, so that the inspectorate actually knew where the product was being landed on Australian shores, and then they were able to go out and actually ensure that the product was being fabricated appropriately. The next level was around the training of the inspectorate itself. So having developed the code of practice, then the inspectorate was able to be upskilled in their ability to do what they needed to do. And one of the silver linings, if you like, of the COVID pandemic was that it delayed the deliberations of the task force. And as a result, we were actually extended the duration of our tenure. And that gave us a chance to understand what happens over time when you've got an initial media and political interest in a subject matter, but if it doesn't subsequently translate into behaviour change in the workplace, then it's all to no avail. And so what we saw at the task force level was the need and the recommendation for a licensing scheme to control the distribution and fabrication of the product so it can be processed safely. Just to remind people of the numbers, so in Queensland, we've done one of the most comprehensive screening programs, and we've probably got at least 95% of the workforce in Queensland. And so when you put together the workforce screening that was done in Queensland and Victoria, we're talking about an estimated workforce of 3,000 to 4,000 people, and we've sampled now nearly half of that. So we're actually talking about quite significant numbers from an epidemiological perspective. And when at first diagnosis, you're finding 356 cases out of 1,500 people assessed, that's where we've now got a numerator and a denominator that gives us a pretty reasonable indication of just what is the prevalence of this particular condition. So one of the things that I believe is that every case of silicosis is actually a sentinel indicator of system failure, because if we actually take a strategic approach, control exposures, And if we focus on respirable crystalline silica, then we're going to prevent the full scope of preventable occupational respiratory diseases. So the legislative framework, just to cover that briefly, statutory intervention only occurs after there has been a breach. By that time, it's too late for that exposed worker. And what it means is that there is no trigger or system to enable the statutorily empowered investigation into the circumstances or the case. And there's no framework to enable a medical practitioner to notify the regulator about the worker who is diagnosed. Now that has now changed so that we do have mandatory reporting. It requires a change in the process. The other attribute that I would highlight to people is that I have been unable to find a case of silica-related disease that's been reported in any history that was compliant with the prevailing regulatory requirements of the day. People do the wrong thing either by naivety or by design. And so what does that mean is that while changing workplace exposure standards is a very important piece of the puzzle, it's not the solution. And for politics to actually rely on exposure standards to say that, you know, oh, we've done a good job because we've lowered the standard, it doesn't work. And so what I recommend that codifying the industry practice, license sectors of the industry and police the regulation, and we're going to have much better control. So in Australia, we've now, since 2019, I was part of the working group that put together the very first code of practice managing respirable crystalline silica exposure. That has led to a national code of practice that is a model code that then applies to all the states and jurisdictions across the Australian influence. And then most recently, we now have extended that into managing respirable crystalline silica in construction and manufacturing of construction elements. And this particular code of practice comes into enforceable state later this year. Because we found that it wasn't adequate to just do education and regulation, we found that the engineering stone license scheme needs to occur, and this has been trialled and developed in Victoria, where Ryan Hoy is resident. And so as a model for future practice in Australia and controlling exposure, we're looking forward to seeing the impact of that. And the early reports is that it is effective. So I'll hand the baton back to the...
Our next speaker is Dr. Melanie Gorman-Ning. I hope I'm pronouncing her last name right. This is on utilizing the Canadian BC Safety Construction Alliance Silica Control Tool and recommend interventions from the tool. So Melanie, if you're ready, that would be great.
Okay. Hi. Thanks, everybody. So I presented on the Silica Control Tool at the previous webinar on Silica, not the one that was last week, but a Silica webinar last year for Workplace Health Without Borders. So some of you may have already seen a little bit about it. Let's do a refresher quickly before I show what we have on our engineered stone. And I work for an organization called the BC Construction Safety Alliance. We're a local industry association, and our mandate is to develop health and safety resources for the local construction industry in the province of British Columbia in Canada. And one of the tools that we've developed is this silica control tool to help the construction industry to manage silica exposure at their work sites. Just a summary of what the tool is. It's a framework to help construction employers to make use of existing data that is out there in the literature, or that we have obtained from government databases or industry databases, or some of our industry members have shared their silica exposure data with us, so we can put it into our database. And we also aim to educate employers and workers on the hazards of silica exposure and effective methods of control. And then also the tool, it guides people through a process where they enter information about the work activities that they're doing. And at the end, the tool produces a effective and data supported exposure control plan for their work activities. And for the employer's perspective, it reduces the effort and the cost associated with doing that, because not all employers have access to occupational hygienists who can come out to their work sites and do sampling and create custom reports for them. So it allows employers to get some kind of evidence-backed plans in their hands that they can use and put into their workplaces as soon as possible. And also because we at the BCCSA, I'm a certified industrial hygienist. I have a PhD in occupational hygiene research, and so I kind of vet all the data that goes into our database. So we're kind of making sure that people, when they do these assessments, it's underpinned by good quality exposure data, and they're using that in their risk assessments. So the tool, the way it works, we have a database of over 5,000 personal respirable crystalline silica measurements. And then we've developed a linear regression model based on that database using some of the determinants of silica exposure in the construction industry, including the work activity that people are doing, the construction sector that they're in, any engineered controls that they're using, like wetting or ventilation, the work environment, like is it indoors or outdoors, or is it in a kind of a cramped, poorly ventilated space? And so the tool in the background, when people enter all the information about what they're doing, it runs the model and creates an estimate of their exposure level. And it can do it, in many cases, it can estimate their exposure both with and without the control measures, so that they can kind of see the difference and see the effect that the controls are having on the exposure levels. And it compares it to our local exposure limit, which we have in BC, we have the ACGIH TLV of 0.025 milligrams per cubic meter. And then it creates a written plan that they can use. Yeah, so most of our, it's focused on construction. So we don't do anything. We're not for manufacturing facilities. So most of, I don't know if there are any of these in British Columbia, but if there are, I think there might be some. If there are some facilities that manufacture these products in British Columbia, they would be kind of outside the scope of our mandate, but they would still have access to our tool. But some construction employers may still be exposed to silica dust from these products. So we have tried to locate some data that we can use to include it in the tool. The only source of data that we found that kind of met our requirements for quality assurance and also had enough information on the work scenario and the controls used was this one. It's a report from NIOSH. They did a health hazard evaluation program report, evaluation of crystalline silica exposure during fabrication of natural and engineered stone countertops. This was published in 2016. Now, it was a while ago that we did our kind of scan to look for papers that were relevant to engineered stone countertops. So if any of you know of any exposure data sets that may be useful for us that we could add to our database, please contact me, let me know. But this is the one that we have in there at the moment. So I'm just going to close my PowerPoint. I'm just going to show you what we have in the tool for this so far. Okay, sorry. Oops. Okay. So, and you guys can see this silica control tool. It says hi, Melanie. Can everyone see that now? Yeah. Okay. So this is the interface of the tool. I'm in my personal dashboard on the tool. So I'm going to open up this project that I started earlier, where I'm going to estimate the exposure levels for polishing artificial stone and/or granite countertops. So I'm going to open this project. But when I do this, it kind of runs us through the whole exposure assessment again. So here it just gives some information about the tool. There's various, orientations, and you can click on the links to get information about the risks of silica exposure, etc. This is the link to our local regulation where people can find out more about what the requirements are. I'll continue. And this, it shows you just this pathway where it tells you exactly what to expect when you run through the tool. Here you enter information about your company, who's the contact who developed this exposure control plan. And this is all when companies, when they do create a final document based on their assessment, this is all this information is pulled and put onto that document. And that's kind of used for, you know, like if an inspector comes onto your work site and says, what are you doing about silica? You can show them this plan. And then they can determine whether or not it's appropriate or whether or not you're actually doing the things you said you were going to do, et cetera. So now I'm going to enter some information about the job site. So there are drop-down menus for the variables that contribute to the exposure, the predictive model. So one of them is job site sector. So in this case, I'm going to say it's a residential job site. And it could be new construction, renovation, or demolition. I will say it's going to be a renovation, because I think when people are doing new construction with these products, they usually just install them kind of whole. They have a whole piece and then they install it. So in a renovation, they might be more likely to be disturbing the silica in the product. So then in these drop downs, this is where you define the work activity that you're doing. So we have a whole big list of common construction materials that people might be working with. One of them is artificial stone or granite countertop. So I'll select that. Then you go to the next drop down where you can select the task. For these products, we have 2 tasks, grinding and polishing. I'll select grinding in this case. And then tool is a grinder. Continue. Work area and duration. This is another, so these are more variables that contribute to the model. So if it's indoor, outside, or in a restricted space, I'm going to say in this case it's inside. And the duration of work, it can be less than 4 hours, 4 to 8 hours, or more than 8 hours. I'll say we're going to be doing it for 4 to 8 hours. That kind of gives you, if you're doing it for less than 4 hours, it reduces your exposure level to take into account, you know, the fact that you may not be exposed for half of the work, at least half of the work shift. So just to kind of get a kind of, not quite worst case, but sort of exposure level, I'm going to select 4 to 8 hours. And then it asked me to review all of my selections, just in case I want to change them. I can go back and change them if I want to. But I'll continue. So this is where it calculates, in this step, it calculates the silica exposure level without controls. Now, unfortunately, we don't have any data on exposure levels without controls for this activity. So it can't actually do that. So what it does, it comes up with this warning that says, we don't have data to calculate this. But we do expect that it's above the exposure limit when it's uncontrolled. So you're going to have to control it. So we don't know how high it is, but we know it's higher than the exposure limit. So please proceed to control. So continue. So this is where you select the controls. And it goes through the hierarchy of controls. So it asks you to consider whether or not you can eliminate or substitute the activity. I'll say no in this case, or use a different material. Engineering controls. The only one that we have available for this activity is wetting, that is built into the grinder. Or if you want, you can proceed and say that you're going to use a different engineering control, but in that case, it won't estimate your exposure level. It'll just kind of prompt you and say, well, okay, you can do that, but you need to collect your own measurements. Or if you say you don't want to use an engineering control, it says this is not recommended. So I'll proceed with wetting integrated to the grinder. And then it also, and because we're going through the hierarchy of controls, now it has a list of administrative controls that we really should use. And I should have said, actually, for the engineered controls, there is a link that you can click on that shows you, if you are going to use this control, you can't just use any wetting. It needs to meet these criteria. And it's the same with the administrative controls. There are tabs that you can select that tell you, exactly what it means. If you say you're going to be doing inspections and maintenance, like what is that? What does that entail? And if you're not going to do it, you must say no. So I'm going to select all of these administrative controls that are all best practices: housekeeping, decontamination, training, preparedness for emergencies, work shift scheduling, barriers to isolate the area, etc. So I'll continue. And then again, it gives me a summary of all the controls that I've selected. So I'll continue. And yeah, in this case, we still have a high exposure level for this activity. It's 0.105, and that exceeds, I mean, it certainly exceeds our exposure limit here in British Columbia, and it exceeds all the other exposure limits that I know of for most countries, although there probably are some that have higher limits, but it's a pretty high level of exposure. So because it's still a hazardous level, you have to continue. And this is where basically it tells you that you need to wear a respirator. If you have to do wetting and also wear a respirator, and it gives you some examples of the type of respiratory protection that is required. In this case, you need a protection factor of 10. So if you click yes, I'm going to use a respirator. Now you can proceed because your workers would be adequately protected in this case. And you can also select if you want the workers to wear coveralls to protect their clothing. And yeah, this is the documentation where this is where you can go through and print out your plan. And yeah, so the other activity that I have in here is the polishing, and the exposure levels for that one are a bit lower. So I think in that case, if I went through that activity, it shows that you still need to use the wetting, but you can do it without a respirator and be below the exposure limit. The exposure limits are the exposure levels are about a quarter of what they are for grinding. So yeah, so that's basically all I had to show for today. And again, if any of you are aware of any sources of exposure data for this activity, please let me know and I can add it to our database. Thank you.
That was great. Thank you very much. Super useful. There was one question about, can it be used by a non-Canadian company or organization?
Yeah, so at the moment it is because because it was paid for by the BC construction industry to develop this. They are not making it available to just everybody yet. So you need a login at the moment. If anybody's interested in just checking it out though, for kind of just for information purposes, we can provide guest logins. So contact me as well if you're interested in that. And we are also working on a version. We're working on getting it adapted across Canada, and we've made some good progress in the provinces of Alberta and Ontario to have it adapted there. Really, we would like to have more people to have access to it. So that's something we're working on.
Nice, thank you. All right, our next speaker is Dr. Susan Hambling on lessons from the Health and Safety Executive.
Hi, I'm Sue Hambling. I'm a chartered occupational hygienist and a specialist inspector, and I work for the HSE, which is the Health and Safety Executive. It's part of the government in the UK, and we have a regulatory role for control of substances hazardous to health. I'm going to cover 4 topics briefly: a bit of research that we did a couple of years ago on research on artificial and natural stone, what guidance we have available at the moment, regulatory enforcement, because we've just started a silica intervention campaign, and mention a government paper that's been reported recently on silicosis. So moving on from that. Right, in terms of the research, this was a project that was done in a lab. It's for dry cutting and dry polishing were the 2 activities we were looking at. And then we were looking at emissions from them. This tunnel that you see the schematic of is about 10 meters long, and it literally has air coming in one end. Where it says XY traverse is either where we had a cutting blade or we had a polisher, all automated, so there was no human variation in the experiment. And then the fans got rid of the turbulence, if you like. So we were trying to get isokinetic sampling. And then we had various measurements that we took, real-time device monitoring, but we also had a load of samplers on the mannequin to pretend to be a person. So we were collecting various types of dust and particle fractions and so on. We looked at both natural stone and artificial stone. For the natural, we looked at a granite and a sandstone. For the artificial, we used resin-based ones that were polyester styrene resin and the sintered stone. We did look at other resin-based stones, and I'll mention those slightly later on. When we go on from that, what I'll do is just show you a few bits of the experiment. There's a paper available on this, and the link is in the presentation. If you have any problems with it, come back to me by email and I'll send you the paper. We looked at dust emission. So we looked at inhalable, we looked at thoracic, we looked at respirable for 1 sintered, 2 resin-based and 2 natural stones. And we found that there really wasn't any difference between the individual stones. The plot there literally just shows respirable when we were cutting, but likewise for thoracic when we were cutting, all of them were fairly similar. Inhalable when we were cutting, all the stones are fairly similar. And likewise, when we went on to polishing, although the levels were lower, we still found there was no difference between the types of stone. So whatever we're doing in terms of processing, we're breaking down any bonds or anything that might be there because of the resin. We looked at the dust peak profile and found from the polishing gave us much smaller peaks, around 0.1 and 2.5 microns diameters, whereas what I've shown you there is from cutting, where it was around 6 micron and 9 micron diameters, all into the sort of respirable, small side of thoracic. And the third plot on there was when we were actually looking for the silica within the various fractions that we'd collected on an impactor. And what we were finding is that irrespective of the size of the particles, the amount of crystalline silica was staying the same in each size range, if you like. And it was very similar to the level we were finding in the bulk of the stone when we analysed just bulk stone. So for granite and for the sintered stone one there, the actual level in the bulk was about 7%. And as you can see, those values are pretty close to the 7. So what we sort of came to the conclusion was that if we knew the level of silica in the bulk stone, we could estimate how much would be in the dust for any of the fractions. So that was the conclusion from that. But what we did notice is that the not safety data sheets, but the product data sheets often overestimated what they said was in what the crystalline silica content was. So some of the resin-based stone where they were saying 93% quartz crystalline silica, you actually found when you analysed it, it was sometimes 69%, 72%, 81%. So the data sheets, data information you get is often over conservative compared to what we actually found. We looked a little bit at the resin-based stone in a bit more detail, and we did some scanning electron microscopy and looked at elemental maps. The grey picture is the best way of describing it, is looking at the silica particles. The green one is looking at the dust particles. The green one is looking at where the silica is, and the blue one is looking where the carbon is. And if you look, the green and the blue don't really overlap. So our conclusion from that was there's no obvious binding actually between the resin, which has the carbon in, and the silica. So that's why I put those little pictures in. We did various tests looking at the volatile organic carbons from the heating resin-based stone. And we actually chose 4 types of resin-based stone. We did quite a few that were polyester styrene. We did one that had an epoxy resin, one had an acrylate resin, and one had a PET, can't think what it is, terephthalate resin in polyethylene terephthalate. So we did them in a lab test and heated them up to 120 degrees and got all sorts of different organics coming off. Whereas when we were actually, so we were able to identify what might come off with heat, but actually when we were cutting or polishing, the tool didn't get much above about 40 degrees. So the amount we would get off in a real situation, if you like, was much lower than some of the ones we were seeing. So some of the things we identified in lab tests, we probably wouldn't see in reality at any significant level. It's worth noting that what we were doing was we were measuring amounts coming off, nothing to do with comparing with occupational exposure limits or anything. It was just to try and get an indication of what was happening. What we did notice, though, is that the sources of stone that we had from with polyester styrene resins in gave very different emissions depending on the source. Wide range of levels of styrene were coming off, but we were also seeing the terephthalate and the phthalate anhydride that you were talking about earlier, and the C9 carboxylic acid particularly. So I think there's more work to do on that, but we didn't get any evidence that the levels were going to be significantly high enough to cause a problem instantly, but we would like to think more about that. Moving on from that, so that's basically the conclusions. Percentage crystalline silica in the bulk is approximately the same in each dust fraction. Particle size distributions are similar across all the stones. Particles released when cutting resin-based stone did not appear to be bonded, and there are VOCs being released, but at relatively low levels. The second bit was about the guidance. As a result of that, we were fairly confident that the control measures that we thought were adequate for natural stone would be adequate for artificial stone, subject to it having the same level of crystalline silica in. And so we put some guidance together. Some of it's been updated recently. The HSG 201, the first one there, is the more detailed publication. The cost sheets cover specific tasks and identify all the controls we would expect for a specific task. So for example, ST1 covers primary and secondary sawing. You know, ST2 is automated rotary tool usage, that kind of thing. So that link will take you to all of them. There's a simpler version of general background, if you like, to exposure to silica dust control in INDG 463. And if you're new to silica, that's probably where to start. The last one I put on here is a bit out of date, but it might be useful. What we do is we create work plans or operational guidance, if you like, for our inspectors. And that work plan is from 2019-2020, so it is a little bit out of date. But it was looking about occupational lung disease caused by various things, asthmagens, carcinogens, but also respirable crystalline silica. And it looks at a number of industries. And what it does is it outlines the kind of initial enforcement expectation we would expect if certain controls were missing. So it gives you an idea of, you know, how much we think the controls matter, if you like. And we do have different options of enforcement, whether it be verbal, whether it be a letter, which we call a notice of contravention, whether it be an improvement notice, or whether it's actually a prohibition of a task. So if you want to see sort of where we go in terms of enforcement, the initial positions are in that document. They haven't changed a lot since 2019-2020, which is why I've put it up there, because I don't think it's too misleading. But the current version isn't available publicly at the moment. In terms of regulatory enforcement, we do a number of things we call interventions. Some are investigations where there's been an incident or case of ill health. Some are inspections. We do reactive inspections if we've had a concern, and we literally will go out and see what's going on. But we also do plans of proactive inspections where we plan what we're going to do and say we're going to do so many sites in this industry to see what's going on. We also do communication campaigns when we want to try and get industry up to a slightly better standard before we go out and do anything. So for the silica intervention, which actually started last October, it's covering foundries, brick manufacturing, but it's also covering stoneworking, particularly worktops. So we've got the new guidance, which we've just mentioned. We've done a communication campaign in terms of making trade associations aware, in terms of sending out e-bulletins and so on, to say our inspectors are coming to look at these things. You know, perhaps you better get your act in order, perhaps you better look at the guidance, kind of thing. Targeting is on worktops as much as we can, but we are a little bit limited because we use the SIC codes, the standard industry codes. And it doesn't necessarily break that industry down quite in the way we would want. So some of the visits we do won't be to worktop fabricators, but at the moment about 2/3 are turning out to be what we want, as in worktop guys. So we do a proper inspection, we'll do enforcement if they don't meet the standards. That's fine, that's what we would normally do. And normally the inspectors would just record in our system in a sort of free text way with 1 or 2 prompts, if you like. What we started doing this time is actually asking them to fill in a few questions on a questionnaire afterwards, because what we're trying to do is get some what we call exposure control indicators. They're effectively leading indicators, but it's trying to get a baseline so we actually know exactly what's going on, so that as things improve, we hopefully are going to be able to say there'll be less ill health. So they have a set of questions afterwards to answer. You know, how did they see, was water suppression used? How many, you know, how much was it used? Was there dry cutting used? Was there health surveillance? Things where we can codify the information to get that baseline as a starting point. We've only done probably a quarter, I should think, of the visits we're going to do to stone fabricators at the moment. They've got till the end of March to complete them. We're finding all sorts of stones being used, which is what we'd expect, but we need to break it down a bit more and see how many places are using both artificial and natural, and how many are using high silica stone, particularly where they could be using something else. We are quite pleased to see that a lot of them are using water suppression, which is interesting because our guidance originally was much more onto dry cutting and extraction, and we've changed the slant, and it seems to be working in the sense that more of them are using it. I've put down water walls. This is a type of LEV, but it's kind of like a water pre-filter. It's like a water curtain that's a pre-filter. We have a few concerns with those because we're not actually sure the filtration works well on the respirable particles. So we're trying to find out how many companies are using them and whether they're actually using them in a recirculatory mode, which is where they're often advertised for, where you can't duct externally. So that's one of the things we do have an issue about, that we're thinking about. Monitoring, very few of the companies we've been to so far have done any monitoring, and none of them seem to be using real-time devices, which is something that our government seems rather keen on, and I'll mention that in a minute. And then health surveillance is still one of those things that we're finding in the bigger companies, and we're finding the SMEs just don't understand what it is, never mind having any. So we are picking up issues, and we hopefully are getting them to improve. And the last bit I'm going to mention is about the government APPG report. What our government has is various all-party parliamentary groups, and there's one on respiratory health. And back in 2020, just before we all went into lockdown, they issued a report called Silicosis, the New Asbestos. And that was based on information from Silica in construction. A number of people, not HSE, I hasten to add, did a bit of lobbying on the government, and they're particularly interested, saying there's a lot more technology around now, that report needs updating. So they have gone through the process of updating that report, and the report has just now been published literally a few weeks ago on improving silicosis outcomes in the UK, and there's a link there if anyone wants to go to it. There are recommendations in that report. I think there are about 4 or 5 on clinical aspects and 5 or 6 on regulatory, and I've paraphrased them just to fit them on the slide, basically. But in terms of clinical, one of the things they are recommending, is that we make it a notifiable disease again. We did have silicosis as notifiable, now it isn't, and it's very difficult now to know what cases we do and don't have in this country. So that's one of their recommendations. They then had several other clinical recommendations about better communication across the medical practitioners, if you like. So we're in a situation where, you know, if your health surveillance picks up a symptom, does the GP ever get to know about it? If you go to GP with problems breathing, do they realise that if you're working in the stone industry, they ought to be thinking about the silicosis aspect? So it's trying to make sure that if any ill health is picked up, it's communicated appropriately up and down the medical chain, if you like. In terms of regulatory, 3 aspects: raising awareness, which I think we've been mentioned before, that education is important. They're suggesting a syllabus item in any government-funded apprenticeships related to building construction. And they're also advocating that HSE should do an awareness campaign. We will think about it. I don't know where we're going to go with that. HSE, they've also suggested, if you like, HSE should determine data and technology to allow a reduction of the well. And I will reflect on Graham's point earlier that reducing the well will help some people get down to a lower level, but it's not the most important thing for us at the moment, because our regulations are such that we can always ask them to minimise exposure further if there are reasonably practicable measures by which they can do it. So even if they are below the well, we can still say, well, hang on a minute, you're still dry sweeping. That won't do, kind of thing. So we actually have enough regulatory power to keep knocking the level, the actual exposures down without worrying about where the well is. But there clearly was going to be some discussion about that. And they've also suggested that HSE and industry consider real-time monitoring, which is an interesting one. We are looking at real-time monitors, but we're also a little concerned because those supplying them seem to be marketing them in a way that they will magically give you a personal exposure of silica. And you think, hang on a minute, and no, not yet. I think further down the line in the future they may, but not yet. And the last point I'm going to say is that HSE do intend to comment on the recommendations. I don't know what that will be. I have had input to it, and we will just have to wait and see how HSE adopt or don't adopt those recommendations. And that's me.
Thank you so much. That was great. Super interesting. Our next speaker is Dr. Allison Fortner with NIOSH. She'll talk about current progress and ongoing activity with an engineered stone countertop research project that's focused on exposure and medical monitoring, control technologies, and educational research. So there we
Hi.
go.
Yes,
Hi.
thank
Hello
you.
again. Hi again.
Yes. Hi, everyone. It's a pleasure to join today. My name is Allison. I'm an industrial hygienist with NIOSH's Respiratory Health Division Field Studies branch at our Morgantown, West Virginia office in the U.S. And as was briefly shared, today I'm going to talk with you about a research project that we have going on focused on engineered countertop research. We are a few months into the second year of a 4-year funded project. So I'm going to talk about our ongoing activity and the types of data that we're aiming to collect as part of our project. So I'll be brief with these first couple slides in essence of time and the audience, kind of just talking about, most folks in this group today are aware of the concern and need for this research just with increased popularity and the composition of these engineered or artificial stone products and potential for overexposure to silica during work activities. And also just the identification of cases within the US and also globally related to silicosis. So our planned and ongoing projects, given the rapid growth of artificial stone countertop industry and risk for silicosis and other severe lung disease among countertop fabricators, NIOSH is studying ways to reduce exposures and improve disease surveillance. And we've designed our study to have 3 sub-projects, which have the following broad objectives. The first project objective is to enumerate artificial engineered stone countertop facilities across the US to understand industry scale and demographics. The second project objective is to understand industry awareness of silica hazards, personal protective and control technology use, and successes or barriers to implementation of control measures or silica regulations by performing site visits, which will include exposure and medical surveillance. And the third sub-project objective is to have a larger public health campaign to educate countertop manufacturers, the fabrication facilities, and workers and employers on health risk and prevention methods. And the 3 projects are, they're not intended to be conducted sequentially, but rather for concurrent implementation. So working through kind of each of the projects and what we have going on. As a growing industry, it's not really well defined, and the obligation to monitor workers' health might not be known, considered, or understood, and education on potential hazard and health risk is limited. So a public health campaign, which we're focused on kind of as part of enumerating the artificial stone countertop fabricators across the US, we hope can help enhance understanding of exposure and health risk, increase awareness, ultimately aiming to help mitigate exposures and prevent disease, excuse me. We're currently building a directory of countertop fabricators across the United States. So we have identified business information for about 2,000 countertop facilities nationally. We estimate that's probably not half of the countertop fabricators in the US, but it is a start. So this is a living document. We'll continue to build over time. Additionally, with this project, we're working on an upfront educational component and sharing information we currently have available, such as graphics, hazard alerts, links to NIOSH web pages, and resources that are presently available to provide awareness of silica hazards to industries through this directory and through partnerships and relationships we're developing with various trade organizations or other folks in industry. We're also conducting a survey with the workplaces that are included in the directory to better understand industry practice and get a sense of the scale and structure, try to learn whether workplaces have any types of respiratory protection or medical monitoring programs in place, or what types of controls they might have, or basic work practice activity. And we're working with industry partners and the workplaces that we're reaching out to really understand and learn things such as nomenclature and what types of messaging would resonate with industry. For example, one of our industry partners had never heard the term artificial stone whenever we started discussing the project. They shared with us that that was totally new to them, and they and everyone that they communicate with in industry usually uses the term engineered or manufactured surfaces. So just trying to be mindful of those types of things whenever we are sharing educational information and reaching out to workplaces. The second part of our project, which includes the exposure and medical monitoring. So we're seeking opportunities for partnerships with fabricators and interested collaborators to perform on-site exposure assessments and medical monitoring to better understand hazards, work practices, any feats or challenges, and really aiming to gain insight on what's going on in these fabrication shops from an exposure and health standpoint, and learning from site visits what's working, and identifying ways to reduce exposure and improve disease surveillance. So for exposure assessment, we're planning to use time integrated and real-time monitoring to identify factors that might contribute to higher or lower exposure, such as the type of product being used, fabrication equipment designs, operating conditions, whether general exhaust ventilation or any local exhaust ventilation exist, and kind of evaluate that variability in silica exposures. And in addition to that, we are looking at some of the mixed exposures and aiming to measure what was just previously mentioned, some of the resins, other additives, and metals that might be present in these various materials, and kind of use that information that's been collected and information that's been evaluated on kind of the efficacy of control technologies, and hopefully develop targeted implementation strategies for the fabrication facilities. For medical monitoring, we're aiming to pilot enhanced respiratory surveillance of the engineered stone fabrication workers. So due to the potential for developing silicosis following silica exposure of less than 5 years, enhanced respiratory surveillance of workers beyond standard medical monitoring requirements could help identify preclinical disease. So we're aiming to partner with industry and state-based collaborators to pilot enhanced surveillance, which would include low-dose computed tomography, LDCT, and diffusing capacity for carbon monoxide, so DLCL, and compare that with results from standard medical monitoring requirements, including spirometry and chest radiographs in the same workers. And then kind of the final part of the project, the education will be rolling throughout. So once we've collected the data and maybe have changed or thought of some different potential targeted recommendations, we'll continue to sort of refine materials and educational information and distribute those with relationships that we hope to develop over the lifespan of the product throughout industry. And so ultimately, we'll use the knowledge gained through partnerships in our research to provide immediate stopgap recommendations to lower possible workplace exposures until broader mitigation strategies and educational materials are developed. And being a part of this webinar today and the community of folks researching this important topic, this really been informative. And hearing about all of the work going on globally, I appreciate everyone's time and the opportunity to join today. Put up my contact information, and then Dr. Reed Harvey is my co-project officer. He is leading the epi medical portion of our research project. And I'll stop there. Thank you all so much.
Our next speaker is Jason Green from WHWB Australia, and he's going to talk about working safely with artificial stone, a fabricator's perspective. Hi, Jason.
Hi, Audrey. Can you see my screen?
Yes, perfect. And I can hear you. It's great.
Excellent. Great. Excellent. Thank you so much. And thank you, Kevin and David, for putting together this webinar. It's amazing to see all these experts coming together and chatting about everything that we are really concerned about. So I'm a past president of WHWB in Australia. I'm based in Sydney, and I'm also a consultant with a company called GreenCap, which is owned by WSP. So I'm going to quickly just run you through artificial stone, working safely with it, and really focused on what the fabricators are sort of looking at essentially. So I'll brush over this slide because I think we've already discussed these sorts of things, but essentially it is crystalline silica and the respirable fraction, which we're really concerned about. You can see here my little arrow here that we're really focused on that respirable fraction, and then sort of in that lower end 1, 2, 3 micron level. And then as we've heard as well today, we've got that chemical component within the material, as well as metals such as titanium, aluminium, things like that. So just wanted to quickly frame the situation of what we're looking at with the fabricators and what their work entails. So we've got a primary workplace and we've got a secondary workplace. So that primary workplace is where the fabricators are generally there at the majority of their time within the factory, within the workshop. And so we're seeing that those workshops are well set up. They've got multiple controls in place, and they're very well set up and relatively controlled within their exposure. I suppose in comparison to that is that secondary workplace, which is the installation point where the actual countertops or the bench tops are actually installed on site. So you may think that the countertops are totally ready and they just essentially install them on site. Well, unfortunately, that's not the case. Sometimes they need to make adjustments, small cuts, small sections that need to be done on site. When they get on site, then it may not be exactly as discussed within the contract, so they need to do some adjustments on site, and that's where we can see some potential breakdown of those controls, potentially dry cutting, and exposures are happening in that secondary work area. So when we're looking at fabrication industries and businesses, you could class them as small, medium, and large organisations. So that we're seeing within our assessments and investigations that these medium to large organisations are well set up, they're well funded, but the small and very small organisations, which essentially take up a lot of the industry, particularly in Australia, are not that well set up, and so some of their controls are not as good as they need to be. So yeah, that is a particular issue which I'll go into a bit further. Another thing which we want to be concerned about going forward when we're looking at all of these controls is there's that primary and secondary exposure. So obviously there's that primary exposure that the fabricators are getting exposed to during the actual activity, but then we've got the waste and the dust that accumulates within the workplace. So that is a particular issue which we'll talk about later on with regards to housekeeping. So our main work groups. So we've got our obviously our computer numerical control, or CNC, guys and girls that are on doing the main cutting. We've got the saw operators, we've got labourers, we've got shapers and finishers. These are the ones working on the cut. Once they've been templated out on the machines, and then we've also got other similar exposure groups there, which is your supervisors and people that are working in the offices. So yeah, we can't forget those other supervisors and managers and people in offices, because these workshops, if they're small and medium sort of sized workshops, the officers and the supervisors are very close to the workshop and interact with those areas. So some of those workers can have potentially significant exposures as well. So I just want to quickly share this one from a Queensland code of practice within Australia. It gives you a good sort of spread of the different similar exposure groups of the workers. So you can see here in particular in the red circles here are the higher sort of exposures you're seeing around the shapers, around the finishers and the polishers. They're the ones finishing off the bench tops, whereas your CNC machine operators and your other sort of labourers and other people are getting a lower exposures. So these are just range results here. By the way, I'm sure you can see the spread of results there. Please note that these samples were taken by regulators while the fabricators knew that they were being monitored. So I certainly have seen higher results than that on other sites. All right, so let's jump into that hierarchy of control. So I'm not going to go through this right now, but we're going to step through it step by step and just really sort of unpack all of those ones that we're seeing. So elimination, as we know, ideally we would not want to use this hazardous product, and potentially maybe in the future a banning of this product may be something that countries may look at. That's certainly a bigger conversation, but at the moment we have these materials in place now, and we need to manage them as such. So if we can use non-engineered stone benchtops, that would be good. We want to try, I suppose, and eliminate these products from areas where people are working, and sort of control the use of them for people that are trained and protected. When we're looking at procurement for these sorts of materials, I suppose we would need to control the procurement and then possibly look at alternatives for these types of things. And ideally, we want to make sure that the products are ready to go and to be installed on site. Okay, let's have a look at substitution. So there's a lot of different things we can have a look with substitution. Obviously, there is low silica content materials that are coming out now. I think the suppliers are working feverishly to try and lower the silica content in materials. And I suppose we want to substitute those high risk tasks with low risk tasks, don't we? So we want to use technology and lifting equipment and things like that to try and reduce that overall dust level within the air. When we're looking at the actual cutting of the actual product as well, using very sharp tools, minimizing the number of cuts can essentially lower that overall airborne dust hazard. So things like that would be really helpful to be looked at in these sorts of situations. So with regards to isolation, again, we want to make sure that these sorts of situations are happening, where the use of robotics is now coming into play now, which is amazing. A lot of the larger and medium sized guys are looking at those situations, and it's about, I suppose, segregating those workplaces from the unprotected workers. So the use of CNC machines, the using of enclosures, things like that are really really awesome to see on site. I've just got a little video here for you to look at. This is essentially an automated robot cutting into the stone, and it just this is a source from Edstein Creative. Thank you so much. And so I'll just quickly show you this video. Small prize if someone can guess the artist and the song while playing.
I'm not getting any volume. I can't hear
Oh,
anything.
no volume? Oh, no. Okay. It's not coming
I
through.
was
Sorry about
looking
that.
for the song.
Okay. For people playing at home, it's Coldplay Clocks.
Oh, love that song.
So sorry about that, everyone. The audio didn't come through for some reason. So, but yeah, I mean, you can clearly see there that the work area is segregated, and so it's essentially removed from those workers. So it would be really great if that could be put in place. All right, so let's have a look at there. So let's move on to engineering controls and dust suppression. So when we're looking at dust suppression, water is a huge part of what we need to see happen on site. And unfortunately, using a hose from a tap is not going to cut it. We need very sophisticated spraying and the use of different types of nozzles to essentially capture that dust within the air. We're dealing with extremely tiny respirable particles, so the use of atomized type dust suppression is really important. So you can see on the side here, if we're using those large particles, we're not getting that slipstream effect, so then that electrostatic force is not essentially knocking out those dust particles from the air. When we're looking at using water as well, so certain surfactants can then be put within the actual water to then essentially increase that surface area, so then that can again increase that the likelihood of more particles being removed out of the air. Okay, so on tool water is absolutely the way to go now for all of these different types of cutting tools and polishing tools that are being used. Local exhaust ventilation, I suppose, and general exhaust ventilation has its place, but when we're using a lot of water, then there's problems with local exhaust ventilation. But yeah, there's a lot of different types of things that are being retrofitted now, and you can actually buy a lot of these products ready to go, and you can essentially install the water straight into the tool, and away you go. This one up the top left is a cool one. So people have actually used a portable spraying unit there, connected into the actual cutting tool, so then they can actually cut wet quite well on site, for example. It was mentioned before about the use of water mist and using of flaps and things like that. So you can see here, there's down the bottom middle there's use of flaps to try and reduce, I suppose, the airborne water and dust there. Has sort of a limited sort of application there, but I suppose we want to make sure that that it's constantly the use of water all day, every day for these types of activities. So with that water as well, I suppose we some places like to filter and reuse their water. So we want to make sure that filtration is adequate, so that they're not essentially recirculating contaminated water around the system, which can then overall increase the issues there. Okay, let's jump into administration. There's lots of different things there that we can do. Essentially, housekeeping is a major issue on these sites, because they're generating a lot of dust, so that material can accumulate within the workspace, and then we can see those secondary exposures, which we mentioned before, around that dust, that dry dust, being resuspended into the air and then accumulating or compounding that airborne risk. So we want to see really the good use of cleaning and the use of M and preferably H class vacuums for silica dust. For using those things, you can see here up the top here, there's some people have got decontamination units and dust removal booths that they use on site, which have been quite effective to decon people's clothing. Obviously, we can do air monitoring and real-time air monitoring. So you can see here that obviously someone with a cyclone set up here for respirable dust monitoring. And then in the bottom right here, this is actually real-time monitoring of different types of applications of dry cutting. And then we've got sort of the use of water, and then maybe a combination of the two happening there. So I think real-time monitoring is a really important thing going forward, which I'll talk about later on. And then obviously, yeah, just laundering and separation of those work areas and areas for people to clean themselves and decon and shower if need be. All right, so there's an amazing initiative through the Australian Institute of Occupational Hygienists, which I'm part of, called Breathe Freely, that was essentially augmented and from the BOHS in UK. So thank you very much. That has really been a huge step change in Australia. So there's a really awesome section in there around engineered stone. So I encourage you to have a look at that on the AOH website. So that goes into a lot of sort of training materials and things like that. So yeah, I mean, I think that awareness and that training is really important, and I don't think it's used enough in workplaces. So another really important thing to do for fabricators as well is health surveillance. So they need to be able to get access to that health surveillance, and if they make sure that their businesses and their bosses are making sure that happens, and that it's paid for by the businesses. And so we want to see, I suppose the other thing around that material that we're finding on site is that it needs to be managed and it needs to be removed. So that waste management piece you can see here on the right-hand side here, it's a hopper essentially gathering all of that dust on site. So that needs to be managed. So we need that the regular removal of that material from site needs to happen, and then it's around, essentially it's can be essentially removed off site, but I suppose that transport of how it's moving off site is really important. All right, moving on from there, let's have a look and have a quick chat about monitoring and real-time monitoring. So obviously active and respirable dust monitoring is really important to get that actual exposure for the people on site. So that personal or exposure monitoring is really important. That needs to be done to assess the risks and assess the profiles of the different similar exposure groups. But I think the future is real time, and the future is hopefully real-time respirable crystalline silica. So there is obviously a lot of things out in the market now. I'm sure people have seen and heard about the Trolex units are very good for real time. There's also other things like the side pack here, and there is other units you can out there that have a gravimetric attachment as well. So getting this real-time data and real-time information around the activities and things like that are happening on site is really important for us as hygienists to indicate to the workers and to the businesses the particular issues that they're finding on site, and the higher risk sort of situations and activities, so that they can really work on those and try and reduce those real exposures on site. So I think the researchers and the inventors are still trying to finalize the actual legitimate real-time RCS monitoring. So hopefully in the next few years we'll see some prototypes coming out of that. There is some really good on-site XRF units. This is one here, for example, which you can actually do on-site XRF analysis of your filters, which you can be super helpful for getting a result relatively quickly as well. All right, moving on from there, I suppose our last line of defense is respiratory protection, isn't it? So as we sort of been mentioned before and on this call as well, because of the high exposure risk and the severity, I suppose, of what people are exposed to, and the need for multiple controls, respiratory protection is very important, and it truly is the last line of defense for these fabricators. So we want to make sure that they are using the correct masks. Obviously, they're getting those risk assessments done so they can assess what types of masks they need to be using. Obviously, that we've got that lower level of control when we're getting, I suppose, up to 10 times the exposure. Standards is your P2 half-face mask, which is something similar to this one down in the bottom left-hand corner here. But then when we're moving up into that higher range of exposures, we really need to see some more mature and higher risk type respiratory protection needs. So we want to be looking at essentially full face respirators with either negative pressure filtration, or there's an example of a clean space here, which is actually essentially a PAPR or a powered air respirator. We want to make sure that people are sort of being provided this respiratory protection, and making sure that it's controlled and managed and kept in a very dry and clean environment, so that they can be using respiratory protection that's not inadvertently contaminating them. Again, another awesome initiative from the Australian Institute of Occupational Hygienists is RESFIT. So RESFIT is a respiratory protection initiative for accrediting or people being able to be accredited respirator fit testers. So fit testing of people. So I think that's a really good thing that needs to be done for people that are wearing tight-fitting respirators. They need to have that fit testing so that they can ensure that they're getting a proper seal when they're wearing their masks and respirators. Obviously, as we know, there's issues with facial hair, so we want to make sure that facial hair is taken into account, and that ideally we want our workers clean shaven all day every day, but that's not always the case. So I think that that whole conversation around respirators and a respirator protection program is another really amazing thing that fabricators need to be put in place. So I think I'm just about done. So there's my references there, and happy to chat further later on. So thank you so much. And my little plug for today is, again, please think about joining the WHWB. So thank you so much.
Thank you very much. Nice plug too. Yeah, thanks, Jason. Our next speaker is Kate Cole. She's past president of Australian Institute of Occupational Hygienists and in Australia, and she's going to talk about advocacy in Australia. All right.
Thank you so much, WHWB, for pulling this webinar together, and thank you for this opportunity to share the important work in this space that we've been doing at the Australian Institute of Occupational Hygienists. I'll just start with an acknowledgement of country. I'm coming to you from Gadigal land, which is Sydney, Australia, and I acknowledge the Aboriginal peoples as the traditional owners of the lands and their custodianship of the lands in which we are all, or I am coming to you from today, and I recognise their valuable contribution to Australian and global society. Also, just a very quick disclaimer, I don't have any conflicts of interest, but I will declare that on behalf of the Australian Institute of Occupational Hygienists, I am the co-chair of the National Silicosis Prevention Strategy Expert Steering Committee, who was charged with helping to develop the National Silicosis Prevention Strategy and National Action Plan, which is due to go out for consultation in Australia Monday next week. I'm also the chair of the AIOH External Affairs Committee, and in my private capacity, I am a consultant occupational hygienist, so I'm an independent expert witness for government and legal firms, mainly for silicosis cases, unfortunately, and I'm a consultant largely to the infrastructure sector. A very quick bit about us at the AIOH. We are the peak organisation that represents all the occupational hygienists in Australia. Our membership is rapidly growing, which I would like to put in part to advocacy and what hopefully I'm going to be speaking about eloquently today. We have about 1,500 members at the moment, and we run 3 major programs, one being Breathe Freely Australia, which Jason has spoken about, and also RESPFIT. And in addition to that, we have the AIOH Foundation, which funds grants and initiatives, all with the aim of creating healthier workplaces in Australia. So Part A of this webinar series went through the numbers of workers with silicosis and the background of the National Dust Disease Task Force. And I'm going to go through the science of exposure, compliance, safe work practices on a broad scale in Australia, but I'm going to take you through it all through the lens of advocacy, because advocacy plays a critical role in shaping the political environment and informing health and safety policy. In the Australian context, and likely internationally, it is politicians, it are ministers, not scientists, that decide if laws are created, if policy is adopted, if funding is provided for compliance initiatives, and if programs are supported through funding or not. The vision of the AIOH is for a healthy workplace for all, and we can only achieve this vision if we are really active in this space. So some key questions that we need to ask ourselves early on to know if we need to even do anything about the silicosis crisis are here on the screen. What does the evidence tell us? What are the gaps in our knowledge, and do we need to fill them? What's our position on the issue? Who else shares this view? Who else are our friends in this space? And after we've done all of this, are things getting better, and is everything acceptable? At the AIOH, we've been active in the area of advocacy for silicosis prevention across many sectors, but today I'm just going to focus on engineered stone to provide some examples to these questions. And I would also like to acknowledge that this comes from the work of the External Affairs Committee, and I'm very fortunate to lead it. But I have a fantastic team of people, many of whom are on this call and are far more experienced and intelligent than me. So I'm just the one that gets to communicate it all. So kudos to EAC. So what does the evidence tell us? Well, Dr. Edwards and Dr. Hoy went through prevalence rates in Australia in part A of this webinar, so I won't represent their excellent work, but I'll summarise to say that 1 in 4 manufactured stone workers with silicosis based on Queensland and Victorian screening programs is completely unacceptable. Poor chest radiography and spirometry sensitivity for screening stonemasons occurs, and yet some states and territories still rely on these methods to screen our workers. Safe Work Australia, which is our federal government body, completely discounted the option of low-dose, high-resolution CT scanning in the minimum requirements for health monitoring. Unfortunately, we don't have a national register for silica-related disease, although one has been promised. We do have some state registers, but some only include some silica-related diseases as notifiable, not all of them. So in summary, the evidence tells us that the number of cases of silica-related disease in Australia are likely much higher than the numbers that have been reported to date. So I didn't want to kill you by PowerPoint, because I don't know what time it is in your area of the world, but it's pretty early in Australia. But I've pulled together just a quick snapshot of what some of the evidence tells us. So we know in stonemasonry, meeting the current workplace exposure standard in Australia of 0.05 milligrams per cubic metre is challenging, even when you're wet cutting stone. We know that international studies of workplaces have reported really poor work practices. We know that in at least one state in Australia, New South Wales, it's reported that only 15% of businesses had any form of personal air monitoring report. So it tells us that air monitoring isn't getting done appropriately. We've seen observed low levels of compliance, many improvement notices by our regulators. And our regulators are not able to get to all of these businesses very often. We also know that there's disparity in our states. So some states get more inspections than others, some get more notices than others. And we know that commonly issued improvement notices, at least in New South Wales, relate to inadequate health monitoring, like not being done, safety data sheets, no training for the use of PPE, fit testing, really basic stuff. So to summarise all of this, it means that compliance and enforcement in this issue, on this area, is an issue. Secondly, we know that high quartz containing engineered stone has toxicological properties that are distinctly and qualitatively different to natural stone. We know there's an issue with really fine particles. We know that the types of tools used in fabrication and the quality of water used for dust suppression makes a big difference. And we know that not all the information that's on safety data sheets is always accurate. So in summary, we know that natural stone is not the same as artificial stone, not just in quartz content, but with many other areas. So we know that engineered stone is different to natural stone. It's more than just the quartz, and we know that labeling and safety data sheets are an issue. But sometimes as scientists, you reflect and go, well, is it just us that sees this evidence, that reads PubMed, that speaks to other professors, that tries to inform our knowledge? Like, is it just us? Are we missing something? Well, the evidence also tells us that Caesarstone's annual reports have started to make declarations about limitations for their product liability insurance. And we know that in our country, at least one major insurance company has begun to implement policy exclusions to some exposed trades and industries in response to the costs of rising claims. So we also know that the insurance industry understands the risk, and it's not just the scientists. And when those who hold the purse strings start to feel the impact, then you know that it's a really, really big problem. So then we looked at, well, what are the gaps in our knowledge and how do we need to fill these gaps? And I'll be honest and say we did have quite a few. Up until very recently, we did not know whether the people that are involved in assessing workplace risk and advising on controls in the workplace, those on the front lines being occupational hygienists, we didn't know what this issue looked like from their perspective. We had a hunch, but we didn't really know. We didn't have evidence. We also didn't know if air monitoring was being performed appropriately. And we didn't know what proportion of exposures to silica dust were exceeding or having the potential for exceeding, for higher exposures, I should say, well above the workplace exposure standard. We also really didn't know the level of employer awareness in this industry. We have seen some stakeholders count clicks on a Facebook video or a website as effectiveness of engagement, but we actually wanted to know, well, how much of this message is actually getting out to employers? Do they understand this? And to that end, we didn't know how effective regulatory interventions had been holistically applied. So we didn't know if we're on the right track or if we needed to do more. So we worked to fill that gap, and I'm going to present some really high level information from that exercise, but you can read our published paper in the Annals, which was published late last year. Essentially, our External Affairs Committee developed a series of questions that was open to all of our members in Australia. It was a completely anonymous survey. It was conducted in March to April of last year, and we aggregated all the information to ensure anonymity. So first off, the survey showed that the level of concern regarding overexposure to silica dust in Australia was high. So occupational hygienists are telling us that they are concerned, and this is still a very big issue. Participants were then asked about their experience on the level of awareness of employers on the risks of exposure to silica dust across different industry sectors. And the chart here shows that the highest level of awareness was reported in mining and quarrying, then construction and tunneling, and lastly, by comparison, in the engineered stone industry. So how is it that in 2022, the engineered stone industry, the employers, actually have the lowest level of awareness when all we have been doing is talking about silica dust in manufactured stone? It completely astounds me. When we get to air monitoring, we see that in all three sectors, we see that the majority of survey respondents told us that with regards to non-compliance with the workplace exposure standard, which in Australia is 0.05 milligrams per cubic metre, that some of the exposures are exceeding the exposure standard, and there is the potential for higher exposures. So that's very concerning to us. And when we look at, well, what's the effectiveness of regulatory intervention? We know that the National Dust Disease Task Force identified a number of significant concerns with the existing work health and safety regulatory protections for workers. And one of those was that government interventions appeared to be inconsistently implemented and monitored. And we have noted in our previous public submissions that there has been a failure by regulatory agencies to enforce their own legislation. So asking this question was really important. Unfortunately and concerningly, participants' responses were consistent in their highest response, with somewhat effective selected across all industry sectors surveyed, indicating that a more effective level of intervention was present in the mining and engineered stone industry. We wanted to know the views of occupational hygienists when it came to, well, what are the barriers of preventing silica-related disease? And they reported the top three being a lack of management commitment, which is highly concerning, a lack of financial resources for employers to bring in controls, again, very concerning, and three, low compliance with existing regulations. And there's some others on the screen as well. When it came to, well, what do occupational hygienists believe to be the most effective regulatory prevention strategy? They reported the top one being specialist inspectors, i.e. occupational hygienists with detailed knowledge of silica dust assessment and control being in the regulator. And indeed, we see better outcomes when occupational hygienists from our regulators are involved and visit workplaces. So that made a lot of sense. In summary, what our survey and study showed was that the majority of occupational hygienists were concerned about the overexposures to workers from silica, that air monitoring wasn't being performed the majority of the time. They had concerns about exceeding and having the potential for higher exposures. They found employer awareness was the lowest in the engineered stone sector. There was a disparity in the effectiveness of behaviour change initiatives, air monitoring, and the use of real-time monitoring. I didn't go through all of that today, but you can see it in our paper. Regulatory intervention was only somewhat effective, and occupational hygienists called for the need for mandatory reporting of overexposures to silica dust. And just for context, at the moment in some states, when a worker is diagnosed with silicosis, there is a notification that will go to our jurisdictional work health and safety regulator to enable them to intervene. But we know that the latency period between exposure and the onset of disease is a number of years, and in some cases more than a decade. So that's not the most effective way to intervene. We want any overexposure to the exposure standard that's measured by a hygienist for silica dust to be reported to the regulator to enable intervention. So what is our position at the AIOH on this issue? Well, we articulated this recently to our submission to Safe Work Australia on a consultation regulatory impact statement. But number one, above everything, is to progress a ban on the use of high quartz containing engineered stone in Australia, a ban on the importation and a ban on the use. We need a centre for disease prevention and control. Australia doesn't have a US-style CDC, unfortunately, that deals with workplace health. We want a national licensing framework for those that work with engineered stone until a ban is implemented. We want additional regulation for high-risk crystalline silica processes for all materials. Amazingly, prescriptive regulation exists in one state of Australia, but not the others. We do want national awareness and behaviour change initiatives, but it's to supplement everything else. We want to see increased specialist resources to support the effective implementation of regulation in our regulators. We want to see regulatory improvements to product labelling requirements, and we want to see high resolution CT scanning as the mandatory minimum regulatory requirement for health monitoring. Because indeed, when CT scans are used, we see the prevalence go up. So that shows us that likely the existing methods that are used in some states are not finding the cases as they actually do exist. So who else shares this view? Is this just the AIOH in Australia? Are we on an island by ourselves? No, we're not. In fact, for the very first time in our nation's history, every single professional body, association, technical group, unions who have a voice on this issue are completely aligned. This photograph was taken on a recent delegation to our nation's capital, where we met with politicians and those in the power of decision making to advocate for reform, to advocate for the implementation of a ban on manufactured stone, for increased regulation, for increased resources to enable compliance and enforcement activities to be effective. So I guess semi-last bit, are work practices and exposures improving, and are they acceptable? There's been a lot of work since the National Dust Disease Task Force, so maybe it's fine now, right? Recent statements in our state parliament have said that there's been a massive improvement over the last 5 years, both in compliance, education and awareness. And as a result of this, only 2 on-the-spot fines have been issued for dry cutting. And there can be the impression left by some stakeholders that poor compliance around this issue is a thing of the past. And while there has been some improvements in this sector, unfortunately, it's not very difficult to find poor work practices still. So as one example, I'll give you a few examples. I don't have the benefit of going to all the different manufactured stone work sites in Australia. I don't have enough time, but I do have the use of technology and Google Maps. So I just looked for manufactured stone businesses in Western Sydney, which is near where I live. And I used Google Street View to have a look inside some of these manufactured stone businesses. So this is a shot from a site in Fairfield East in Western Sydney. This was taken in September 2020. So when you zoom in, you can see how much white dust there is on the trolley, which is evidence of dry cutting practices being implemented. Further down that street, you can see the dust on the floor, and you can also see the labels, the quartz stone being delivered, being ready to cut. Later on, went to another site, Google Street View, April 2021, this photo was taken, this time in Smithfield, Western Sydney. Again, you can see the amount of quartz dust coming out of this facility, which is highly concerning. This photo was taken from May 2022 from Bankstown in Sydney. It looks like dust is coming out the roller door. You can see the overflow of waste and dust in the skip bin adjacent to the door. Essentially poor housekeeping and likely very high exposures in this workplace. But this is not an issue just isolated to one state. This is a national problem. So I recently put out a call to some people I knew that work in manufactured stone, because I wanted to understand, well, what does it look like right now? Because we know that some stakeholders are lobbying decision makers, saying that everything is fine and it's no longer a problem. So I really wanted to know, well, what does it currently look like? So here are some photos sent to me recently of a manufactured stone site in another state in Australia. And as you can see, yeah, this is non-client. So in summary, exposures are not acceptable and we still have a long way to go. And this just reinforces to us why a ban on manufactured stone is so important, because we believe that industry has had sufficient time to understand their duties under work health and safety regulation. So in summary, the evidence base for us to act is really large. So we've done a lot of advocacy in this space. The launch of the Breathe Freely SIP program, thanks to our partners in the UK, has been fantastic. Also launching the RESPIT program, because despite wet cutting, on-tool extraction, good ventilation, in order to reduce the incidence of silicosis, workers are still going to have to use respiratory protection because the quartz is just so high. At the AIOH, we've contributed to many consultations and made submissions to inquiries and written lots of letters to those in decision-making powers, and directly supported many government committees on this issue, in addition to launching the Australian first survey on the experiences of hygienists in the workplace. The challenge that we have as occupational hygienists and the community professionals who work to keep workers safe is to ensure that the evidence that informs policy is loud And we need our advocacy to be allowed to ensure practical improvements are made to protect workers from this entirely preventable disease. And in addition to all of this, we do tend to be featured in the media. I promise it's not just me, there are many other people also. But if you do see us in the media calling for things like banning manufactured stone or raising awareness of this issue or calling on our governments to act, hopefully now you have a good understanding as to why we do this and why it's so incredibly important for us and indeed everyone on this call to advocate for a healthy workplace for all. Thank you for your time.
Thank you so much. I imagine a lot of us have used Google Street View, but never thought of it being used for industrial hygiene. That was really great. Thanks a lot. So now we have the panel discussion, advocacy reaching developing economies, Q&A really open to everyone. And I know we've gotten a lot of questions in the chat box, but feel free to raise the questions now once we've begun the panel discussion. I think, Kevin, you want to give us some help with that?
Sure, I just want to start, there was a paper that I came across years ago, and it was kind of related to diesel exhaust. And the name of the paper was Wait for the Evidence or Wait of the Evidence. And, if you think about the precautionary principle, you also think about all the different ingredients in artificial engineered stone, phthalic anhydride. And I noticed, aluminum's sort of been detected in significant quantities. And, that thinking about the very small particles that people are inhaling, and also thinking about the advocacy that's done in Australia. I don't know, I think we have a great opportunity here to leverage on some of this great work. I'm just thinking, like many years ago through Dr. Claire Wood, she drafted a letter with Graham Edwards' input and others' input, where we actually sent this letter to ministers in Australia, with recommendations. So we kind of combined our forces with different organizations in Australia, a bit like what you're talking about, Kate. So I'm just thinking collectively through this forum. So when there were about 360 people registered on this webinar, and we're down to 143. So typically we probably end up we had 48 different countries registered, and there's going to be many countries where they might have one or two people, from those countries. So how do we kind of reach those countries that might be importing artificial engineered stone? I'm not sure if Jen Galvin's on the line. So Jen is actually the president of Workplace Health Without Borders now. Collectively, could we kind of draft a letter, a template, and put it on our website, for those in developing economies to use in their own countries to raise awareness? So just food for thought. I don't know if did you want to say something to that, Jen?
Thanks, Kevin. The only thing I can say is we're trying to find a way. We don't want to put words into people's mouths who know their government officials better than we do. We don't want to use words that are not familiar with in your culture. But we were hoping that if we drafted a letter that had some salient points that all of you could use in a letter with your appropriate language to your ministers and or other important officials, that this might be one way forward to have our voices, our collective voices heard, and that possibly or potentially the collective voice may be stronger or better heard than a single voice. Any comments or thoughts about that? Would people use such a letter?
It would be nice if we could say, X number of members of WHWB share this opinion or something to give an idea of the volume of people that are interested in this group.
Yeah, I guess we can only just, you know, there's that old expression, you know, it can take a horse to water, but it can't make it drink.
Yeah.
So it's really just raising awareness internationally. I mean, you know, the cases in California, the migrant Spanish workers that the Bob Harrison's talked about, like, you know, if you don't look, you don't know. If you don't do the screening, you don't see the silicotics. So it's really about how do we actually collectively raise the level of awareness. And the other thing I just want to put out there is I actually thought that engineered artificial stone was a bigger beast than natural stone. And I seem to be hearing that, but there seems to be some mixed messages there. I'm not sure. I don't know if Graham, Dr. Edwards wanted to share his thoughts there. You know, it's there is more silica, apparently respirable crystalline silica. Are you seeing worse health effects from engineered artificial stone than natural stone, Dr. Edwards?
The spectrum of disease is the same spectrum, but it's skewed towards the high intensity early exposure. So that's where you're getting the mix of acute and accelerated pathophysiological responses. So yes, we were seeing silicosis in people who had only 3 years from first exposure. So by definition, you're talking about accelerated silicosis purely and simply because time since first exposure to developing disease is a diagnostic criteria. What we also found at the task force is that we needed to be mindful of our labeling of people, because just because someone actually has a short exposure time to detectable disease does not mean that they're on the short rapid train to death, and that people have disease with then a long livable productive life ahead of them. It's just that for many they're going to have a much shortened and disabling life and a distressing death. So we've got the same spectrum of disease associated with the engineered artificial stone, but it's skewed towards those in the more severe earlier stages. And the other attribute that we're seeing in the engineered stone sector is that it's a much, much, much younger age group. And so whereas asbestos-related diseases, we're talking about people developing severe end of the spectrum in their retirement years, they've already contributed to a productive working life in their family and support. With the engineered stone sector, we're seeing people in their 30s and 40s, young families, absolutely distressed, and the psychometric responses are very significant. So the short answer is it is similar and also different.
Thanks. Marianne raised her hand, but first I want to call your attention. If you go down to the bottom, there's a little thing, a happy face that says reactions. If you click on that, it'll bring up a screen where you can put raise hand. So anyway, Marianne.
Okay, thank you. Thank you so much. Thanks all the speakers and Kevin and David for organizing this. I had a question in the chat, and I see Perry Gottesfeld has addressed it to some extent. So Perry, I would invite you to speak up. And my question was, so where is this engineered or manufactured stone product coming from? Where is it actually, the stone actually being crushed and then put together with some kind of polymer? And what are the exposures in those situations? WHWB is, after all, devoted to providing occupational health and hygiene knowledge in areas where it is needed, and we expect it's needed in a lot of those places. So I wonder if Perry or anybody on the call could speak to this question of what are the exposure conditions where it's being manufactured, and in these other low and middle income countries, are there also similar exposures from the installation and the cutting of the stone? And does anybody know about efforts to do something about it?
At the turn of the century, Marianne, a lot of the product was being manufactured in Israel, Spain, Italy, the Middle Eastern countries where the product was originally designed and conceived. Nowadays, the vast majority is being manufactured in Vietnam, China, Russia. The off-market copying of the licenses to the manufacturing processes that were originally developed in Italy is now, rampant worldwide. So the change in manufacturing processes, as we know from hygienists, a lot of manufacturing process change doesn't come about because of work health and safety considerations. It comes about because of engineering efficiency and productivity related to how can we make this product faster and cheaper. And so the processes have also changed. So in many respects, the advances in manufacturing of the product have diminished the exposure to those workers involved in the manufacturing of these slabs of artificial stone. But there's still a very real issue, and there's legacy issues associated with past practices.
Thank you, Graham. I also want to mention that we did have a lot of people registered who are in Africa and other places. I know it's very late there, but if any of those folks are still on the line, I would love to hear what you know about exposures conditions in your country. So thank you. Thanks, everybody.
So David and Alec raised their hands. How about you first, David?
Thank you. I very much want to compliment the speakers. The presentations were very good and very instructive, and in my opinion, very useful as a way to understand what we need to be doing with regards to getting better controls. I do want to ask those of you outside of the United States, but also those in the US, we've got a major barrier related to language. Almost all of the newest 30 cases in California are among Spanish-speaking workers. And I just should point out, Dr. Edwards, these are, or somebody else said, these are not migrant workers. They are workers that have come from Spanish-speaking countries. They're not migrating back and forth. They're working, their main jobs are to work in these countertop operations, many of which are very small, and they have a serious question about how we can take what we know and share that with people with some rudimentary education, none of whom want to get sick by any manner of means. What they want to be able to do is make enough money to support their families and to support, and in some cases, send some money home if they're from other countries. So I just wanted to ask any of you, especially Dr. Fortner, was there any successes that you knew about where translation of English warning activities into Spanish seemed to be effective? And if the answer is I'm not sure, then maybe that's one of the things that we need to be focused on going forward. And just like to have us be aware of that. I don't know in Australia, for example, or in England, if you've got these kinds of problems, but I know that in the US, that's a major issue.
Yeah, I think I'll share for us right now, not sure. And it is something, you're right, it's a very important point, and it's something that we're thinking about as part of our project, and as we're talking to state-based collaborators and other folks working on it, being mindful of that important aspect.
And certainly it is an issue in Australia. Migrant workers or people who have migrated or refugees from other countries. The Vietnamese community, I'm reminded of one case where a grandmother of a worker with a Chinese background actually translated a media release from somewhere into Chinese that then she used to generate a level of angst within her grandchild's sort of family because they were in a different language and with different cultural exposures. Her level of concern translating into a media release into their native language, and then that generated the referral to my clinic on the Gold Coast. So it's a very real problem worldwide in that we are dealing with a disadvantaged group because of language. And the other attribute that you highlighted is that these people are only trying to make a living. Now, these workers absolutely love what they do. They take a raw product and make it into something that is beautiful and valued by society. They see it as a value add. They just don't see that it's killing them.
Right. Can I just ask one other question, and maybe some of you on the phone on this webinar know this, but outside the US, for example, in Latin America, in Mexico, in Brazil, in Argentina, in other countries, we need to have colleagues there understand our work as well, because we know countertops are being made in these other countries as well. And, you know, by inference, that's true throughout Europe. So being able to get health and safety related countertop materials translated is really one of the key things that will help us sort of increase the prevention capability going in the future. I just think that's something we should not lose sight of. Thank you again for letting me chat about it a little bit.
David, I'll just quickly add to what Graham was saying before. I mean, yeah, in Australia, you know, it's the Vietnamese community, it's the Chinese community. There's issues with Cantonese language. We've done awareness training sessions for fabricators, and we've tried to simplify the awareness training presentations. We've had usually the managers or the supervisors have very good English, and some of the other workers don't have good English, and so having them within the actual awareness training sessions to physically see that there is that translation happening, obviously verbally, and then using the pictures and the processes and information, so that we can see from our perspective that the workers are understanding what we're sort of saying within that session. So I think that's an important piece to try and get across.
Thanks. I see Alec has got his hand up, and then Perry. So maybe Alec might want to ask the question.
So can I ask? Are you hearing me?
Yes,
Yes.
we can hear you.
Okay, so I put my question in the chat. We've had quite a bit of experience in health and safety with workplaces which are certifying themselves or being certified and audited by a third party to be meeting certain standards. And I'm wondering if any of the speakers have experience from any jurisdiction with attempts to certify, that is to validate safe practices in this industry, and then use that to leverage supply chains. For example, builders who build a big building with a whole lot of countertops in it, and or consumers. And I will comment, there's been some strange commentary, which I find I really disagree with in the chat, seeking to pose the question as an either or. I guess either we try to work safely in this industry, or we're chasing people out of their jobs. I just had a countertop installed in my home. I avoided artificial stone, it was granite. And the two Latin American workers who came were incredibly safety conscious, and they were complaining that their company has trouble competing with the fly-by-night companies, which are working much more quickly and in a very unsafe fashion. So here are like two immigrant workers who are right in the middle of a situation that they're probably being pressured to work unsafely, to work faster, and they don't want to. They want to be protected. So I'm just throwing out as some way of leveraging supply chains and consumers.
Certainly, Alex, that's what we have identified in Australia. And so in essence, the experiment from a regulatory point of view in terms of licensing the product in Victoria is in essence what we're saying should be standard practice, where you can then control the line of the product from importation, where it's distributed, who is licensed to actually fabricate the product, and then that will demonstrably reduce the opportunity for those fly-by-night operations. When we introduced the code of practice in Queensland, what did we see? A lot of the work go over the border into northern New South Wales, where they did not have a code. And so you know, the business goes where it's easy to do, and as a consequence, it needs to be a unified, coordinated response across all levels of governments, across all levels or jurisdictions within at least the Australian states and territories, because we're a federation of states and territories, not dissimilar in many respects to the United States of America, because obviously each one of those states are independent regulators at one level. But we have certainly seen an improvement. I have an artificial stone benchtop in my kitchen that was put in 2004. I know that people died as a result of the work practices that was meant to fabricate my kitchen benchtop. My mother at 90 wanted a engineered stone kitchen benchtop. I allowed it to happen because I got to choose which company did the fabrication.
Thanks, Dr. Edwards.
Very helpful, thank you.
We might go to Perry, and I was just wondering if I could just invite Dr. Dino Pisaniello from Australia. I did see a paper that they produced where they did some really good work on characterization, and it kind of relates to the thing that he put on the chat in the chat box. So is that okay, Perry? And then if you're okay with it, Dino, you can ask the question and provide the context. Thanks.
Yeah, I was just responding to David's earlier question regarding the origins of this material. We did a lot of research on this a couple of years back with partners in China and India. And one thing that we know is the US is the largest importer and the largest market for artificial stone. There is at least one large manufacturer in the US, but most of this seems to be imported. And we're about a decade ago, there were a handful of companies that made this material under license. There's now more than 50 companies that make this material around the world. And for a while there, China was really the leading manufacturer and exporter, but the US slapped very high tariffs on China in around 2019 or so. And at the same time, they put very small tariffs on India. So we saw overnight the Indian industry grew enormously and the Chinese industry shrunk quickly. And exports to the US are still up by like 500% overall, but the shift of countries is what's interesting here. And what's really disturbing about all of this is, although we are learning more and more about the fabricators and installers, we know next to nothing about the quarries where all this is from, and very little about the manufacturing side. Although there have been some good published studies from China, there's been nothing from India, Vietnam, or other countries where this is now coming from. So I agree, David, with your point that we need to really knock down the door of our colleagues around the world to get them to look at the origins of this material.
Thanks, Perry. And I just noticed in our registrants list, we might have had about 8 or 9 people from India. So, you know, if we can just reach out and to everybody here from all of those other countries and share this information, that's what we're trying to do here. So Dina, would you like to share your thoughts behind your chat there?
Well, can I just say that in Adelaide, South Australia, we're undertaking some basic science. Some of it's in collaboration with the Scanseti Centre in Turin. Over there in Turin, they do have some world-class basic science being undertaken on silica in particular, and sort of revealing mechanisms that we hadn't really thought about previously. So one thing that they can do over there in Italy, and I'm sorry there's not that kind of person on this call, is that they can work with the formulators to alter the composition and look at things separately. So sometimes we have this sort of complex combination of materials used in the final product, a technical specification, but we haven't really been able to unravel which bits are most important. I take Graham's comment that, you know, we've got this complete spectrum, but why in shifting is that happening? There's still some answers required. We're aware of what Susan's been doing in the UK, and in particular with characterizing some of the VOCs and whether or not the fine particles are exactly the same as the bulk material. I think there's some differences that may arise because of the way the resin breaks down. So it's still a story to be unraveled, and I just want to put in a plug for the basic science, which supports the kind of stuff that Kate is talking about, the advocacy. You know, we need to bring in some of the evidence as well, although clearly we need to take a stand on a number of these issues because that's what scientists need to do.
Thanks, Dino. And just referring to a comment that Kate just put in the chat box, you know, it's how much is a human's life worth? And, you know, to get into the argument around economy versus people's lives, it's a really important discussion, you know, point. I remember in Australia when I was studying there, and we're talking about mining in Queensland. And I remember there was a kind of like the philosophy was, if you can't mine safely, don't mine at all. You know, certain mines with faults and, you know, problems with mining, they just don't mine there. So it's an important kind of point here. So we've got 10 minutes left, and I'm just trying to think of the best use of the 10 minutes. I would still like us to kind of collectively draft something that we could put on the WHWB website in a kind of a generic way, and then, you know, different people could take that and use it in their own kind of sphere of influence, so to speak. It would also be good to carry on talking about this, you know, collectively, like just to give it legs. And, you know, this whole hazard identification characterization, it's so important because when we're talking about, you know, elimination and substitution, that's where we should be focused. And also thinking about like licensing. I think what's really been very important is, you know, if these manufacturers, fabricators can't comply, I think it was by 2024, then that was kind of like the stick that would be used. So I maybe we could just quickly go to the speakers and then just have a final word. Maybe that's the best use of the final like 9 minutes. So we might start with you, Dr. Edwards. Did you want to just like try and distill down some of your thoughts just before we close out?
I think that my salient message is that there is no one panacea answer. It has to be a combination of everything. And the only way we're going to get there is with the types of advocacy that Kate has championed, and whether a ban will ever occur, it's the threat of ban and it's the emotional attachments associated with what a ban might mean that actually gives it some political weight. As a member of the task force, we said, if you don't get the act together and do it properly by July 2024, then we will be calling for a ban. And as a college, we still hold that position. We can see that in theory, it can be done safely, and we can maintain jobs, and we can create a life after what was and what is, but only if it's done safely.
Thanks, Dr. Edwards. We might flip to you, Dr. Fortner. Did you want to share some of your final thoughts with us?
Yeah, I'll just give a parting, thank you for being able to participate in the conversation today and hear from everyone. And I think, really this multifaceted approach moving forward with, exposure measurements, medical surveillance, and education, how to reach such a diverse workforce will be really critical moving forward. And again, thank you for inviting me to participate today. It was great hearing from everyone and the work that's going on globally.
Thanks, Dr. Fortner. Okay, over to you, Dr. Hambley. Thanks to you as well, for sure.
I've just unmuted myself. Well, yes, I'll echo that and say thank you for the opportunity to participate. I think the two things that I'm picking up at the moment particularly is about the understanding of what exactly is in the artificial stone. And whilst the idea of a ban would be brilliant, I'm not sure it's realistic for a while, but the composition as it's changing, as they're looking for alternatives that are less serious, if you like, you have to be a bit careful that they're not putting something else in that's going to create another issue. I saw something recently where someone glibly said, oh, we'll just replace it all with amorphous silica, it's not harmful. And you think, well, it's not as harmful, but don't start telling me it isn't harmful, there isn't a risk. So I think keeping an eye on what's going on in terms of the composition is an important one. And the second bit I picked up particularly is about the installers and the cowboys effectively, because we don't have a way of controlling at the moment what's coming into the country particularly easily. And we're certainly getting some kickback from our trade association we have called the Worktop Fabricators Federation, who say that their members send installers out with everything pre-cut and right size and whatnot, so they do very little on site, and they're worrying about the road people who are just buying surfaces, taking them onto customers' driveway and doing all the cutting, all the polishing there and then kind of thing. So the installers are certainly an area we're interested in as well. That's it for me.
Thanks, Dr. Hamling. I might go now to Dr. Ning. The Silica control tool looks really interesting. It's, you kind of took us through the algorithm and basically it was saying that, workers need to use both water suppression and a respirator, just when you went through the algorithm. I don't know if you, and all of the information that we're sharing here might be useful for you, Melanie, as you kind of it's an iterative process, right? So it might be useful to share that with you. But I'm just curious to know what your thoughts are.
Yeah, definitely. Yeah, I'm not really, I don't do a lot of work in this particular area with the artificial stone because basically it doesn't come up a lot in the workforce that I work with, although that probably will change going forward as more and more people start doing renovations on buildings or demolitions in buildings where these materials are present. But yeah, I think that
yeah, there's been a lot of wonderful information and data shared that hopefully we can add to our database and make and make our estimates better. Thank you.
Well, especially for those people that don't have the ability to take samples, measure exposure. That's really
Exactly.
important. Yeah. So, Jason, thanks so much for sharing your thoughts and your great slides as well.
Thank you. Thank you. I'll throw in something a little bit different. I mean, I suppose respirator fit testing and RPE compliance, I think, is a really big thing that the regulators need to step up on and really get serious on the fabricators so that they can prove to us that they're protecting their workers. I mean, I know it's the lowest form, but I think that's one of the many things that we're talking about now, which they're not doing well at all. So I think that advocacy around that, and then I suppose just bringing that more simplistic message to the workers. And I know Alma Galvin's on the call. She gave her insights on the last webinar around that not just translation, but that further learning and deep understanding of the ramifications of what these workers are doing to themselves, essentially. So yeah, that'll do from me.
Okay, thanks. And Kate, you know, we're just really grateful to have you talk to us. Your advocacy has been amazing. After you, I would like to just put it back to David and then Alma Galvin, who did some really great, gave us a great presentation last webinar as well. So Kate, did you have anything, final thoughts for us?
Yeah, I'll try to summarize. So we had a recent study in Australia done by Curtin University that predicted that 100,000 workers in our country would be diagnosed with silicosis, and up to 10,000 workers would develop lung cancer from exposure to silica dust. And without action, what happens is the cost burden from work-related disease just moves from employers under their existing obligations under law and onto workers and the public health system, which is what's happening right now. And if we truly care about not letting workers succumb to this incurable and fatal disease, then we do need to act. And it took us way too long to ban asbestos in this country. And you know, the question I ask is, have we learnt nothing? If 1 in 4 miners were dying from rock falls or rock collapse, we would have solved this issue by now. So yes, we do need to ban manufactured stone, high quartz manufactured stone in Australia. We need new legislation that spans all high-risk silica processes. So not just manufactured stone, but tunneling, demolition, quarrying, mining, construction, because this is obviously a bigger issue. But I appreciate that in Australia, we can walk and chew gum at the same time. We can ban something and put legislation in. It's not a mutually exclusive option. So we absolutely need reform, and hopefully I have managed to articulate just how big of an issue this is in Australia and why we're being so proactive in this space.
Yeah, kudos to you, Kate. Your advocacy has been amazing. So back to you, David. If you want to close out and even bring Alma into the conversation for a minute or two, we probably could do that if you like. Just want to thank you for being the co-host too, David.
Well, Kevin, all thanks are to you for gathering a very good group of people to make some serious commentary about where we are. Alma, I would like to ask you if you could unmute yourself and talk a little bit. This audience is very much of a mixture of people, not just from the US, as you know, but from Australia, from Great Britain, and your experiences can actually illuminate where we need to put some more emphasis going forward. So please tell us what your words are.
Thank you, David, and thank you for the opportunity. I just want to briefly, mention that yes, I totally agree. We need a multifaceted approach in different venues, but the one that I can speak of is how to reach this diverse audience, and again, recognizing the process, recognizing what are their values, what are they thinking, how they can take the messages. So there is a lot of work that we need to do, and recognize that needs time. You know, it requires time, requires to bring them into the conversation when developing the materials and when delivering the message. So they are the one that we need to reach out, that we need to translate or the signs that we are seeing here into, you know, something very simple. And I totally agree. The legislation is one that is very important because yes, a lot of the times in the United States, there is a legislation that is telling you that you need to deliver this in their language, for example, the training, but it's not being done that way. So I will leave it like that. And it's a lot to say, but I really, really appreciate, you know, this is about lives, people that is dying, and we really need to take the time to deliver a right, clear message that sounds into their values and into their language, and not only speaking language, but the language that they live. Okay. Thank you.
Thank you. Okay, back to you, David and Audrey. I think we hit the mark now. We're 3 minutes late. And thanks just to everyone else, all the guest speakers. It takes a lot of effort for these slides together. So I just really want to thank you guys and gals for presenting. Thanks so much. Okay.
I appreciate all the speakers and Kevin and David for putting this together. I mean, it was a lot of work. And thanks to all the participants. We got some great comments and questions, and yeah, it was really, thank you.